Good afternoon, everyone. So I must say, when Lise asked me to join this panel about smart methods, I was really thrilled and excited that I was using smart methods. So I thought she's going to ask me about RDD, quasi-experimental design, and so on. But she said, no, other panelists, smarter researchers are also already presenting this method. I want you to present microsimulation. And for most economists, microsimulation doesn't really sound like smart method. It's old-fashioned, the stuff we did in the 50s that didn't work. So how can you fit into this panel with smart methods? So what I'm going to try to convince you in these few minutes is that it's an old method. It's a very simple method. It's not really smart, but it's very important for policy making. And although academics have stopped using this method for some good reasons, because the investment into the model is too high compared to the outcome in terms of publication. Well, most administrations have kept using these models because they're essential to be able to make decisions about long-term decisions about public spending, about the big picture you need to have. I mean, the type of quasi-experimental method, randomization, brings you knowledge about specific behavior, impact of specific policies. But at the end of the road, policymakers need to make choices about the billions you move from here to there, where to put most emphasis, where to get the money flow in order to improve the overall big picture of the public policies. So that's why, although it's not a big return in terms of academic publication, it is, I think, a method that is still very, very important for policy making. So typically, why it's not a smart method? Well, it's very simple. It's sort of a going micro with trying to get from a population that is representative of a country, of multi-country in some cases, and you want to try to model the processes of how this population is going to age, is going to face shocks in terms of employment, change in career, of earnings, will face some random shocks in terms of health and so on. And you want to model these processes, and you want to model also the policies. And this is typically the hardest part. I mean, modeling processes is one thing economists spend a lot of time trying to do, but modeling the policies, the intricacies of these policies, how some bits can be done and undone by another part of the system is actually very tricky. So once you model all the policies, all the population, and then you want to see how behavior, and you want to model behavioral responses, how this population is going to respond to different change in terms of the policy. And once you have all that, you have the ingredients to try to assess change in terms of policy before you implement the policy. That will not mean that it will rest on previous knowledge about what you know currently about the likely effect of various policies. It will not answer the type of the questions that you want to ask through randomized experimental, quasi-experimental designs. But it will provide a guide for policy making, which is crucial. So typically, dynamic microsimulation, looking at microsimulation over a long period of time, has been used for policy pension reforms. How do you want to do a pension reform without a model that helps you to think about what's going on in 30, 40, 50 years of time? But not only pension reforms, elderly care, of course, is something that we knew is going to be a big question. We have current knowledge about the likelihood that these processes of aging will happen and will affect need for care, and therefore the public finance is going to be affected by these needs for care. That will not happen now, but in 10, 20, 30 years of time. So now once you have this sort of broad presentation of microsimulation, let's go to the basic. This not very smart method, what it is. Well, you need to take representative data. You never have one big representative data set. You have lots of them which are representative of subsample population, of specific aspects of the population. So the first thing that the microsimulator has to do is try to gather information from different sources of data and try to make sense of them. Most of the time they don't make sense. They don't really add up. They contradict each other. But you need to make this cross-analysis of the different sources of data in order to come up with the best analysis of the current knowledge about how the population actually is in terms of all these dimensions, about employment, earnings, consumptions, about the demographics, about the health characteristics. All these information are really key. You need to understand how the population will evolve over time. So that's the second stage, the processes. The first thing is processes is age. We have a probability of dying depending on age, sex, or background, socio-economic background. We need to model that. We need to model the fact that we are a probability of getting married, having kids, getting divorced, and so on, having children, maybe dependent parents, and so on, and having families that move around like in the real life. And we need to model all that to be able to see what's going on. I'm going to take the example of elderly care. Why do we need to have to model these families? Well, a lot of elderly care currently is done by daughters. Daughters take care of their parents. But for some reason, they were historically more likely to have the time to be close to the parents, to be able to take care. What happens if actually labor force participation of women increases over time, and therefore people move around the country and not less likely to be close to their parents? How much of this informal care is going to be affected? How much of the demand for elderly care will be affected by these structural changes? These cannot be answered directly by quasi-experimental design or randomization, because we're looking in the future. But we need to take decisions now. Policy making has to make a decision now about what these implications about these structural changes. So processes, data processes, and then we need to model the policies. So modeling policies is, you think, well, that's easy. You ask the administration and they will tell you what's the policy. But actually, the policies are much more complex. Just modeling the tax system is a nightmare. Our model basically has more than 3,000 lines of code just trying to replicate a small subset of the tax and benefit system. But of course, this is only a subset. You need to, what's the supply of healthcare, what's the type of interactions between local authorities, EU level, and so on. So modeling policies is important just to understand what now is the state of policy making and what actually we're doing. In many cases, microsimulation teaches you about what exactly going on that we don't know, simply because administration is split into different sub-administrations that don't really talk to each other and don't realize that some are doing something that is already done by the other, and that typically none of them also are doing the third part that left some population completely unaffected by these. So being able to model interactions between different sets of policies is essential to understand where to put the money, where the money could be shifted and to try to gain higher returns in terms of policy. So once you have that, you arrive with the fourth point, which is behavior. This is the hardest and trickiest point. Behavior is, you need to have a model of how people are going to react to a change in a set of policy. So that's where most of typically the efforts of economists have gone into the labor market. What will be the type of modeling of labor supply, the likelihood that someone will get a job, will work a certain number of hours, given being offered a typical type of job. So what's decision in terms of retirement when people are faced with a retirement schedule? Well, it's much more difficult in health economics, where you have choices that have to be made by different providers, by the families, and therefore this is, I think, a terra incognita, in the sense that not much work has been done in trying to model these aspects, although they are crucial to understand how the policy making in health economics will matter. You can think, typically coming back in my example of elderly care, that depending on offer and the type of prices that different care are provided with, if the hospital of a PHP is offering for free some care of elderly care, then families might want to use hospital instead of a privately funded elderly care, which is much more expensive, and they will try to make choices depending on what is really the offer by public providers in terms of the various types, and there's going to be switch in terms of behavior. Therefore, you need to model these choices in order to anticipate the type of impact that these policy changes will have in the future. So, in the interest of time, so I have 5 minutes left, but I think I'm happy to leave that to the general discussions. And if there are further questions about this old method, Not very smart, but very useful. And we'll be happy to answer that. Thank you.
Thank you very much for having me here. When I asked Liz how many slides I had for the presentation, she said me no slides. So essentially I prepared slides only for myself. And as a result, I will probably gesticulate even more than my usual gesticulation. So I'm trying to convince you that there are at least 6 main reasons why behavioral economics is actually a smart method that can be applied to health economics. And so really the first reason is relating to the definition itself of behavioral economics. There are many definitions, operational definitions. One which is commonly quoted is actually seeing behavioral economics as the challenge to conventional economics, like neoclassical economics. In a sense, is challenging, especially the assumption of people always making rational, optimizing a decision all over the entire life. I quite like another definition, which is the definition provided by the 1992 Roundtable for Behavioral Economics by the Russell Sage Foundation, which is essentially defining behavioral economics as the approach which is using facts, insights, and methods from disciplines that are actually neighboring economics to come up with descriptively more accurate and more appropriate narrative and explanation of how human people actually take decisions and behave, especially in the context of course, of economic behavior. And in the past, those neighboring sciences have been typically psychology, but also sociology, for instance, medicine, biology. I like this definition because it essentially gives us the first reason why we may like behavioral economics from the health economics perspective, because it's actually why not trying to have a more appropriate account of how actually people take decisions and behave in practice, right? And actually, that is it. So after all, we know that many behaviors are actually affected surely by psychological and biological factors, and it's quite difficult to find an area of behavior which are probably more affected by psychological and biological factors than health-related behaviors. So in a sense, it's quite natural that those actually two fields speak each other more often, and that is actually the first reason why we may be interested in behavioral economics. The second reason is actually that behavioral economics is appealing to the use of randomized control experiment, as Mark already explained. So there is a wide set of situations where we may really want to conduct randomized control experiment. And essentially, from the health economics perspective, here is in a sense is going back to the to an area which is close into the very heart of the health economics, which is essentially the medical jargon of applying randomized control trials in health and medicine. From the health economics perspective, I think here the challenge is actually to work out a whole spectrum and a continuous spectrum of randomized control experiment. Mark had already mentioned. So essentially, we may want to embrace an whole range of experiment spanning the continuous spectrum from the lab, where we have a very tight control on experimental condition. But we all typically use student subject back into the field, involving more and more natural situation and naturalistic framework and stakes, and involving more representative sample of the population. And if you're familiar with a very influential taxonomy in experimental economics, those type of experiment actually have been labeled by Harris or list from the conventional lab experiment into artifactual field experiment, frame field experiment, and then natural field experiment where actually subjects are not even aware they're actually part of an experiment, which is actually, and I will add more on this type of taxonomy, suggesting that actually all this continuous spectrum should also account for online experiment and the web internet experiment, which are actually getting more and more popularity among applied social sciences, applied science in general, and social sciences as well. So the third reason why behavioral economics is appealing is because it reminds us, as F economists, of the driving mechanisms underlying changes in behavior. So very often we are not simply interested in seeing whether the effort or the intervention is statistically significant or not, but we want to know more on the behavioral mechanisms which are actually driving a change in behavior. Which is going back to some fundamental concepts in economics like preferences, attitudes, and it is only looking at those fundamental mechanisms which we can actually conclude something about who is actually behaving in a behavioral, non-rational way from who is actually optimizing. So that is a methodological key point that we don't know whether actually subjects are actually taking optimizing a rational behavior unless we actually know something about their preferences, right? And actually, the whole history of behavioral economics has actually been concerned about measuring fundamental pieces of preferences, such as risk preferences, time preferences, social preferences, and then isolating the departures from behaviorally observed regularities from the one that actually been suggested by conventional theory, right? Let me go into the fourth reason, which I think is quite a key reason. And I'm very much advocating the case of taking, rather than dragging in endless discussion on what is the best way of looking at the behavior. So what is the best predictor somehow? What is the best theory? There is a classical economic theory, the behavioral economic theory is the best economic theory. I'm very much advocating a pragmatic approach, okay? Rajesh Shetty is made in an excellent article exactly at this point recently, and is at the end, what we want is not about the realism of the assumption. What we want to have is something which is really informing us about how we cannot predict behavior in reality. And therefore, we can actually take a pragmatic approach and combining the best tools, the best insights from conventional economics, and the best tools, the best insight from behavioral economics, and combining them in more effective policy tools, right? So, for instance, we can then, when we learn something about the behavioral economics anomalies, then we can use those biases, those anomalies, those heuristics that are affecting human decision behavior and human decision making and behavior in order to design more effective policy tools. For instance, redesigning policies aiming to provide information to the subject, redesigning financial incentives, redesigning regulation tools in order to incorporate some of those behavioral economics inside. And actually, the fifth reason is actually more methodological. That is actually is a methodological panel. And actually is going to the direction of making the case that we need to learn more from cross-fertilizing research methods and insights from different disciplines. And actually, I'm meaning this from two perspectives. First of all, and going back to the point that all the other speakers already mentioned, first of all, what we need is a toolbox of methods, not just one method. And of course, there are scholars in behavioral economics which are strongly making the case that theory, econometrics, and behavioral economic experiment are not in opposition to each other. Actually, are complementary research tools which need to be integrated and actually making use by according to the research questions. For instance, imagine there is a huge gap in the literature on the ultimate consequences in terms of welfare analysis. So if we are assuming that actually subjects are not actually behaving according to their underlying preferences, then how can we evaluate welfare if we need a completely new welfare economic theory, which is actually behavioral welfare economics, which is integrating those insights. And of course, experiments are generating data, and we need a statistics, and we need econometrics to analyze the data, right? And the second meaning for having a toolbox as method is actually starting from the observation that there is a naturally high potential to cross-fertilize method and linking data, especially in health, right? Because first of all, we need to somehow capture all the possible ramifications of a policy intervention. Or if we pay someone to quit smoking, well, presumably, that the person will quit smoking. Well, that is not a big surprise to economists because we live in financial incentive. The question is what is going to happen later in that same behavior or in other behavior, F behavior. Is going to license himself or herself more in other related F behavior? Is going to trigger a positive spillover down the line? I don't know. We don't know. Okay. And the other reason is actually that, and as already, Mark has already and Andrew has already mentioned to this one, essentially that in health economics we very often rely on self-assessed health and self-reported health, while we may want to move beyond the self-reported health in many ways. In a sense, it's interesting to see how the behavioral economics and experimental literature and the health economics literature has proceeded separately insofar. The behavioral economists actually running a wide spectrum of randomized control experiment from the lab to the field, and the health economists are typically using large data set, taking advantage of administrative records like the health episode statistics that has been mentioned by Andrew before, or even more recently using biomarkers data. So in a sense, it's as if those two approaches can be very fruitfully and usefully integrated. Why not actually running behavioral economic experiment, conducting a link in those data with survey data, administrative records data, biomarkers data. So there is a huge potential to integrate approaches and insights from making those two approaches talking more each other. And finally, and I will finish, the last reason is actually that behavioral, by working together, behavioral economists and health economists can actually have quite an impact on how policies are actually drafted. At least in OECD countries, there is a surge in interest by policymakers in integrating the behavioral economic insights into policymakers, as witnessed by the launch of the Behavioral Insights Team in the UK, the Barack Obama administration order 2 weeks ago of testing policies using behavioral economic insight, and so on and so forth. In a sense, that is actually actually suggested us to join forces in a new network which we are establishing together with colleagues here at Paris School of Economics and other leading universities in Europe to establish a European network of people, of researchers using behavioral economics experiment in health in order to get also closer to the conversation with policymakers. Thank you very much.
Well, thank you all for your excellent presentation, and it brings fruitful thought. Now, what I would like to, well, it's time for general discussion. Maybe what I would like to do is a very simple comment about starting with what Sherry said about the existence of administrative data, which has been quite often mentioned, and the fact that they are there, and we should really try to get the best of them and make the most of them. And in a way, it has been already alluded to by Emmanuel Bakri, which is the so-called Pharmaco Epidemiology, which is simply a way to use a large data set to look at situations where essentially randomization is not possible in health economics, like looking at the effect of drugs on the elderly population, which is absolutely impossible to do in a randomized trial, or also for small children. So what it would be interesting to see, it has been already alluded to, but how to combine randomization, behavioral economics, and so on with administrative data, which already exists. And we should definitely make the most of them, because they are there and they may be questioned very largely. They do not depend on specific questions where sometimes we use for randomized trials, and they can be used for more general purpose. But it's simply a remark saying that we should maybe think about it and not simply forget, because they also bring a very interesting econometric subject, which is how to deal with bias and selectivity bias, and how to go back to a situation where we use the data as if they were randomized, which is a very interesting challenge. Okay, so maybe before giving the discussion to the floor, maybe among the panel, there are a few things that you want to say regarding each other.
I think it's interesting to try and sort of draw the strands together, and as you say, see the connections between the different presentations on methods. Thinking of Matteo's presentation on behavioural economics, I suppose the question that comes to my mind is to what extent the applied econometric methods that we use in practice have already been influenced by the development of behavioural economics, to what extent they may be sort of further influenced in the future. So Matteo particularly focused on the insights from psychology in terms of individual decision-making, individual behaviour, the subjective biases that may crop up, the rules of thumb that people use to adapt to those. I wonder whether, and I suppose what sort of an initial reaction to that is that strikes me the importance of allowing for heterogeneity across individuals in the way that they do respond to policies, the way they're affected by interventions, which may influence both the way we estimate treatment effects, but also the way we interpret the evidence coming out of estimates of treatment effects. Because I guess there's a sort of there's a symmetry, there's a mirroring between individual heterogeneity and getting the functional form right in terms of the relationship between treatments and outcomes. So you can express it either in terms of every individual having a different linear treatment effect, or there being a non-linear relationship between treatment and outcomes. So perhaps one thing that's where there's a connection between applied econometrics and behavioural economics is the importance of individual heterogeneity in responses. Another one which Matteo was more focused on individual behaviour. I wonder whether another area where we might already have seen an influence and are likely to see greater influence in the future is more on the sort of social psychology side of things. So the importance of social interaction, the importance of networks and so on, both among citizens, amongst patients and amongst providers, medical professionals. And I think that could well influence the econometric methods that people use, allowing for social interaction, allowing for correlation across individuals in that sort of way.
Quickly, yeah, yeah. Thank you, and I think I cannot agree more on the need of integrating econometrics and behavioral economics more closely. I think is the issue of heterogeneity of treatment is really central into the recent literature in experimental economics, especially in field experiment, and trying to disentangle what are the heterogeneity and also the different responses. And of course, also personally, very sympathetic to the view that we need to move a bit beyond individual decision making and more socially textured behavior. And actually, probably the behavioral economics approach is not the silver proof that actually solve everything. So, for instance, in many health-related problems like smoking or overweight, being overweight and obesity, there may be need for more macroscopic policies, which are not simply you can achieve by nudging people to the correct shelf. Yeah, thank you.
Okay, I suggest that we start the discussion with the general one. Yes?
I would like to know whether there are methods to evaluate the therapeutic effects of some drugs. You know, when you are a clinician, you have to go through a randomized clinical trials. In some cases, this would involve thousands of patients followed for years and years to show an excess of morbidity or mortality, especially in the cardiovascular field. So I wonder now all your data, is it possible and also there's a criticism about this kind of trials, because we are thinking of non-real world patients. You know, they are sophisticated, standardized patients, but not really the one we are interested in. So I was wondering whether there are any methods now with this big data, whether you could really predict, or not predict, but analyze the effect, let's say, of a certain class of drugs at least, and the influence of morbidity and mortality without having to go to these very expensive, long time type of trials.
So there are trade-offs both ways, and sometimes you're very lucky, and because of rule application, for example, and I think that actually I haven't seen it in hypertension, but one can easily imagine that you could do this kind of thing very nicely in hypertension, because there are strict cutoffs that are established for treatment, and you could look at people on the two sides of the cutoffs and probably do, I'm sure somebody's done it, probably do quite an elegant quasi-clinical analysis. You know, you can't do the same kind of, you can't be as sure that you've got true randomization when you don't have true randomization. You just can never be as sure. On the other hand, the loss of generalizability in the randomized clinical trial done in academic medicine is so large that this is actually a trade-off I think we should be considering legitimately. We want, I think, to see both standards of it. So one of the questions that came up is the Oregon experiment and why they saw such small results for hypertension. And I think the best explanation is that in the real world, the treatment of hypertension is not as successful as it is in clinical trials. And so when you apply the treatment of hypertension in a sample of low-income people in the real world, you see improvements in hypertension, but you need much more power than the researchers had anticipated to detect the size. The size of the effect is not what you anticipated from the trial. And the reason is the doctors are not as good, the patients are not as compliant, no one is really checking up on them, they have comorbidities, they go home and they don't take their pills. And so even though you observe the increase in medication that you expect to see, and you observe the increase in visits, you don't see the same reduction in blood pressure that you would get in a carefully done randomized trial. Now, what's the right answer? You would like to know both of those things.
Yes, I will add some comment on your comment, because, of course, the effect size in the randomized control trial is much higher than in the real life. But the reason is that in randomized control trials, people are very selected. And why do we select people to be included in randomized control? To decrease the variability and therefore to be more likely to conclude. And the objective of randomized control trial is only to prove a cause-effect relationship, but not to prove the effectiveness of the treatment. There's some solution with data collected in real life. This is to use the propensity scores, which weighted the probability to receive the treatment. We use this, but I know that it's not recognized by everybody because it's difficult to weight and to calculate the probability to receive one treatment or the others. But it's used, and there's some. Yeah.
I mean, I didn't include propensity scores in my discussion because I didn't have enough time. But it's another one of these methods that we can use in real data to do this. I think that's right.
No, if I can add something, there are two issues in your question. So, as health economists, or I'm not a health economist, by the way, but as economists, if we happen to work on health, or as social scientists, if we happen to work on health, the question of interest to us is the one that Thierry mentioned. It is not if a treatment is, as a medicine, something effective. It is if it is socially something effective, which is a different question than the. So you might be right to select the right person to see if precisely the physiological things that are going on are going on the way you expect them, and then you have an entirely different, somewhat different question, which is in real life, because of observance, because of many reasons, this working, and you could have. I mean, you may want to have randomized trials to answer that second question, just like the Oregon experiment did. So it doesn't imply that you don't want to have a randomized experiment as a method to answer that different question, which is in real life, in the social environment, is this still working? Although technically it should be working. So that's one thing. The other thing is that, so the propensity score approach, I mean, you have to be aware that there are very strong hypotheses, much stronger than in the RCT. So it's just, I mean, it's not enough to say, well, there is this thing around and we can use it. You have to be aware that there are, I think, in most cases, very, very strong hypotheses. And my feeling is that when you've done that, you're not sure what you want to think about it. Is it true or is it wrong? So I'm not sure this is a very, 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 you're not, I mean, not very a comfortable situation. And there's much literature comparing the propensity score matching with a trial, with a randomized trial, that find very different results. And some find similar results. So this is really a piece where you don't know where to stand.
About our randomization, perhaps it would be more clearer if we make the distinction between a trial or another kind of experiment to show positive effects or to show negative effects. To show positive effects, it's possible in a lot of occasions to really randomize. If you are looking at negative effects, you cannot randomize. It's forbidden by law. I mean, by law, and for a lot of reasons. So you have really to rely on observation only. You cannot really randomize as it's a regular RCT. So there is a lot of people thinking, at least among people working in pharmaco epidemiology or even in epidemiology at large, using novel methods like Mendelian randomization and things like that, trying to find pseudo randomization from observational data. So I cannot go into details now, but there is a lot of thinking about it.
Thank you. I'm always surprised by the fact that in the healthcare system there are many randomized trials to test drugs and so few to test intervention programs or economic things. Is it due to the fact that clinical trials are highly sponsored with many incentives for the clinicians and that there are no incentives and no sponsoring in the other field?
So that is part of it, but to be fair, I mean, that is part of it. So one would never want to discount the fact that money matters, especially in an audience full of economists. But the other issue is that most of the interventions on the economic side are organizational interventions and not individual interventions. So the advantage of doing a randomized trial with a pill is that you give the pill to 500 people and you don't give the pill to the other 500 people and you have a trial. If you want to do an intervention on what happens if you change the composition of the nursing unit from fully trained nurses to less trained nurses, you need 500 nursing units and 500 nursing units for your control. It's actually a much more costly and difficult trial. So part of the reason we are a little more reluctant also to be fair about it is that it's a more difficult issue.
Can I add something to that? Which is, in randomized controlled trials in a medical setting, trials are stopped if a drug has been shown to have huge benefits, but normally those people who are in the control arm don't object. The problem is when you start doing controls on behavior of organizations, is people in the control arm don't have any incentive to collect the kind of data that you're trying to collect on the treatment arm, so that you're kind of pushed towards doing exactly the kind of thing Sherry's talking about, where you get your control arm's outcomes out of some other data set. Because if you take schools, they all want to be the treated schools. They don't want to be the control schools, because presumably this intervention is going to have a positive effect. So the kind of things Sherry's talking about, where you try and merge administratively collected data, really helps you keep your controls in the frame. And then that's one of the big issues about doing, I know from trying it, doing designs on behavioral interventions in teams of people in organizations.
But money matters a lot.
One of the other issues can be ethical too, because some of the public health interventions are just to promote something that is going to have a proved effect on the health of the population. So you can't prevent the control group to have it because you're spending public money on that. So you can't really go for a randomized control trial. And it's the reason why we have step wage design and things like that, because people who are in the control group are going to have the intervention at a time. So it's for ethical reason too.
I would just point out, I think the medical profession has been too timid about doing randomized controlled trials. There have been some extremely controversial ones, including knee surgery or arthroscopies, where they did do randomized blind controls, fake pseudo surgery. They've also done stents on people, fake stents, to test headaches and other things. And you may say it's unethical, but these are hugely informative, and they got volunteers willing to participate in these experiments because it isn't proven science. And there is a lot of the medicine that would benefit from taking that step to experiment on these kinds of trials.
I'd like to come back to the issue, the discussion about behavioral economics. I think to me, rational choice theory is characterized by three main features. One is that we assume that choices are consistent and coherent through time for an individual, and it's reasonable to get rid of that assumption. Anybody knows that we're not consistent. The second point, the second feature is that individuals respond to incentives. And this is certainly something that we do not want to get rid of as economists. I mean, if we get rid of that assumption, then tell me what we're doing. The third thing is the close link between the positive theory and the normative theory, that we have the same criteria to evaluate what is good and how people behave. And essentially, that means that goes back to Bentham, saying that the individual is the best judge, even if the individual makes mistakes, but his or she is the best judge about his or her own future. And I wonder why, which is when you say that conversations, discussions between economists and clinical doctors and public health specialists are easier when we adopt a behavioral economics approach. Which one of this assumption is critical? And if it's the second one, then discussions are easier for bad reasons. If it's the third one, it's also easier for bad reasons, because it leads to a certain, let's say, fuzziness about which criteria we should use. In particular, we tend to spontaneously assume a very consistent objective function in social welfare. So it's, which is not reasonable, and which is not, certainly not consistent with the assumption that individuals are not rational. So there's so I was, if you can develop a little bit about that.
Thank you. Yeah, I will not be able to provide an answer to that question. It's an excellent question, but it's too intricate, I think. But I can simply add something on the second pillar, and nowhere in my presentation, I think, I claim that we need to move away from the idea that people react to incentives, and I think is still a strong tenet in what we know from how people react in life. People do react to incentives. What I find maybe a promising avenue where actually public economists, health economists, and behavioral economists can work together is actually how to design a new generation of financial incentives which are actually incorporating strong and very effective behavioral economic insights. For instance, rather than paying £100 to change your behavior, playing around biases such as loss aversion, regret theory, and in a that is actually beneficial from both the researcher and the policymaker, which is because if we can change the behavior in a significant way by paying less money and taking advantage of these biases is also more cost effective in a sense. But I agree that the theoretical and conceptual discussion about behavioral health economics is too complicated, and must stay away from it. Yeah, thank you.